we are trying to follow, and we are trying to see the inlet and also the final bifurcation. Sometimes we feel difficulty.
Yes.
Because of the orientation and the ambiguity of the structures.
Just because of poor echo windows.
Right.
Actually, main limitation is in adults.
And the problem is that in my country, in Bangladesh, we are from Bangladesh, the cardiac MRI is in infancy, and CT is also heavily dependent on adult echocardiographers.
But that way cardiac CT is developing. Because we always used to sit with the radiologist to have a final diagnosis. We always. Cardiac CT can't be in isolation for the radiologist. We have to be there. Because what information we want clinically, they don't know. So the development of the evolution of cardiac radiology is this way.
And this coordination is still lagging in my country.
But we have to make efforts.
Yes.
I have a very simple question for both of you. Do we have any cardiologists doing a CT?
Yes, sir. Actually, imaging. Our few colleagues have gone into imaging only. And in South, Dr. Mahesh Manish was here with Escorts and then went to Kochi. He did his fellowship from Kochi. So he's doing very great work, especially cardiac MRI. He's only doing imaging. And Dr. Shanti, she is in Chennai.
In Delhi don't have.
In Delhi we don't have. So she is also just into imaging, not into clinical things. So people are that way moving into imaging fields.
A lot of people who are doing only cardiac MRI, who are pediatric cardiologists, doing cardiac MRI, mainly in USA and UK, but
they are like
two people.
I have a student from my place who was here for about 12 years back. He went to US, did his fellowship in cardiology, and now doing exclusively cardiac surgeries. Fortunately to be Indian, like Gupta based in Florida now, doing just imaging, like his main core of work is imaging. And when he joined imaging in cardiology, I said, Mohit, what you are trying to do? He said, sir, मेरे को तो सिर्फ imaging CT और MRI करना.
Financial feasibility is an issue in India. Financial feasibility is not there.
Anyway, let's look at the slide. Anything abnormal in this slide? Whatever we have taught,
Yes.
let's see our exam, whether we have done good or we have done bad.
There's
I don't know, Sana, here is your pointer. You tell me the central one is what is wrong with this thing.
This is LA, but I think this is RBA. This is RA. It is functional LB.
So I would agree with one point that ventricle is okay, but I don't know about atria.
Yes. This is appendix, and this is a triangular. I think this is LA.
Yes, you are right. I would like to have more confirmation.
More confirmation
on
about
the
that.
atria part.
So, as far as this image is
But
concerned,
I also
There's
see
one
some veins.
very important point is veins. It could be ABBC, anything. So veins are not gathered. The consistent feature is that circle, aorta, descending aorta. Descending aorta always goes with left atrium. So whatever the anatomy, left, right, inversus, solitors, this and this, aorta is related to left atrium. In fetal, I start with that. Okay. So you just look at that circle. So that is descending aorta. This one. Yeah. So this is descending thoracic aorta, and so it has to be it. Okay. Pulmonary vein, don't look at it. If you are seeing it is good. If not seeing, yes, because in they are different. But aorta is, that relation is consistent.
Sir,
Okay.
this right side is RA, left side LA, because IVC draining to the RA. You told that.
Yes. But we are not able to see IVC properly here, that's why. If you
This
see
is
this
IVC,
is
sir.
if you think that is the IVC, then yes. But I am still not sure.
My drain is also
you have to
RA.
open up and say that, but this appears to be atrioventricular discordance.
Of course.
Like in 4-chamber view, RA appear bald, LA receive pulmonary. Okay, normal 4-chamber view. So if you look at this view, the right sided atrium, it's bald. Okay, and left is getting something, and plus that circle. So I have 2 points to say that this is left atrium, and right is bulb. This is the typical feature of right atrium.
This is one point everybody asks, impact of procedure sedation or diagnostic error in pediatric echophysiology. Like in our lab, what we do is we'll just scan a child first, look at his saturations. Everything is normal and the child is not comfortable, then we try to sedate him with trichloride phosphate with a 50 milligram per kg body. If the child is cyanotic, I'll never try to do a sedation in these subset of populations. That's what my always a take home message is. Your views for this.
You use sedation only for acyanotic patients.
Acyanotics. I'll never try to sedate a cyanotic.
So if the child is stable, I will do sedation. I will see the patient and then sedation. Like Down syndrome patient, I will never sedate. I have had bad.
You have to be very, very cautious.
So child is distressed, I will not sedate. Child is stable, calm, child is 80 plus, I will give a sedation. So like
And plus,
smaller children.
what I try to do, I give the baby, most of the time, if it is 1-2 year of age, so I do echo babies in mothers. That is a protocol. So sedation has come down a lot. Initially, in our first day, I would say, we used to sedate every child. Living infant, beyond that, everyone. Means it was a protocol, just sedate. Sister, Baris did currently, and a fixed protocol was there. Now with time, because when we started working in periphery, going here and there, you can't sedate. So you just change your protocols, you evolve, you learn things, many things. So making the baby in mother's lab, either bottle feeding or breastfeeding, and that sort out many issues. And plus clinical is very important. Even if he is not comfortable and clinically he is in CHM. What I ask for the Puropet, I give them, they take medicine, they take 1 to 2 hours in OPD, wait, and they become comfortable. So sometimes he is so cyanotic in sort of irritable spell, so I give beta blocker. So these are the things we do in OPD. Take time. You need to give time to these patients actually. There is nothing like patient has come, I have to finish it early. No, we have to have a quite 1 hour, 2 hours, 3 hours. That waiting time happen in pediatric echo lab. Because just coming irritable, giving sedation may kill them.
Makes them more irritable.
and like this, less than 6 month old child will never need a sedation.
Yeah.
Never. See, less than 6 month child, you give soother or something and they will sleep. And also gel, you keep the gel warm, the gel. So like what we don't have warmer, so I keep the gel on my left hand, keep it slightly warmer, then I use the gel. That's how you can use this molecule.
We use a bottle warmer
Yes.
and during winters so that we keep a small amount of jelly in that bottle, put in a warmer so that by the child is comfortable. And second thing, what we do in our lab is we'll give an appointment, those kind of a thing. We'll quickly scan and give an appointment, ask the patient when your child sleeps. Suppose the mom says it sleeps at 11 o'clock, 12 o'clock. So ask him to come at 11 o'clock, 1 hour before. Prevent feeding for 2 to 3 hours. The child is crying, weeping and everything is there. By the child comes to your place, the child is absolutely irritable. Give them a feed on mother's lap, the child will sleep automatically. And that's a time to scan.
And in fact, when I give the baby to mother, put jelly, okay, so they just get used to it, so they are waiting with jelly and you do. Same way we do ECG. We just put the, fix those electrodes, give to mother, give them time, and when he is comfortable, you just acquire the ECG. So just different technique you need to see what works on particular child. There is no fixed rule.
And
But sick child, better not to see.
Better not to say. And one more thing is a lullaby, like I have my technician, or she's very expert, she'll open up that sound
Yes.
and the child will start sleeping, listening to it, looking at the videos, and that mind get distracted and you start doing the scanning. And we always keep our tongue depressors along with us, they want to bite something. So it's not like sharp because this disposable tongue is a good quality disposable. That's how we work when we sedate a child. And it's a time consuming process. You cannot be in a hurry. for doing a pediatric echo. And I always say to my students, if you have a nursing home, 10 patients in ICU, 30 in a OPD, then 5 echoes, and among them 1 or 2 is pediatric echo, and a wife sitting on top in a residence crying all the time for you, you cannot do a pediatric. So if you want to do a pediatric echo, please take a time out of it, divide your time, give a time when the child is sleeping, not when you want to do it. So that's what the first class take-home message is. Spend time and it'll come out. And imaging is the best thing you can ever have in pediatric or neonatology. In adults, you always suffer with the imagings, but in pediatrics, you never suffer with imagings. And we often use a pediatric, a low frequency, high frequency transducer, but we do a Dopplers, we always shift to a lower frequency transducer for a better evaluation. With these few words, let me say stop and thank you over here for the initial beginning of the journey with the steam engine, because diesel locomotive is yet to come. Alright, any questions before we break and switch over our session to the next one? We can close the recording for the timing.